proceed so that we can be talking about the management of chronic hepatitis B. Now, in most of our practices, many of us will actually be encountering patients who have chronic hepatitis B. How to go about this management is often a challenge to many of us, and I don't blame the general physician or community health outreach person out there who is managing these conditions and who have quite a lot of challenges, because in practice, hepatitis B behaves like an immunological disorder. Now that is a bit big terminology, but I will explain to you in a short while. I think you can see this slide. I'm going to be making it bigger so that you were able to see all of it. Brilliant. If you see it, then that's fine. We can proceed. Now we're going to look at the management of chronic hepatitis B infection. Looking at the introduction, so a little bit about clinical presentation, investigations, and treatment, with how to monitor those who are on treatment. I will explain to you the fact that this is going to be quick. I will be deliberate with the use of certain terminologies and reduce the weighty medical terms to one that can be understood by anyone. And so my name again is Dr. Nemzing Ladep. I am a consultant hepatologist, and I am working in the UK at the moment, but quite passionate about the management of hepatitis B, and would want to push the goal for elimination of hepatitis B by 2030, which is a goal by the WHO. So I definitely would like collaborations in doing this. Good, so we go through introduction, clinical evaluation, treatment criteria, their endpoints, and how to monitor patients who are on treatment, and then cancel them so that you are sure they will adhere to the treatment. And then we will conclude by highlighting certain key points. Now, chronic hepatitis B is defined as the persistence of hepatitis B surface antigen greater than 6 months. Now, that is a simple definition. Now, that does not tell us much about whether there is ongoing damage to the liver or not, but once the marker for infection, which is hepatitis B surface antigen, lasts beyond 6 months, it defines chronic hepatitis B. There are about 4 factors that are important in the management of chronic hepatitis B. We will go through each one. One is when there is evidence or absence of liver inflammation and or cirrhosis. How do we determine this? By doing imaging. The most common ones that are available to many of us, especially in developing countries, will be ultrasound. I do know, however, that the presence of CT scans has been increased nowadays, so we have access to this. You do an ultrasound and it does, sorry, CT scan, and you can see the lobulated appearance of the liver there. It tells you that there is cirrhosis already. This is fluid around the liver. Now, if you do a liver biopsy, you can demonstrate distortion within the liver architecture or damage as evidence. Some cannot afford this, and so blood tests, and a simple blood test looking at liver function test, as well as a calculation of the degree of fibrosis of the liver, will give us an indication. Second point is that there are immunologic response to infection. In particular, there is an antigen known as hepatitis B E antigen. When that antigen is present, it tells us that there is active replication of the virus. I mentioned here wild and mutant viruses. The wild viruses are those that actually have the ability to produce the E antigen. The mutant forms are the ones that are mutated and cannot produce the E antigen. And so sometimes they are multiplying, but you don't have evidence of the multiplication. I'm afraid to say that most of the circulating ones within the African region are the mutant forms. That therefore means that if you rely on the E antigen, you're not likely going to be able to define activity of the virus. And the third factor is the viral load. How high is the number of the virus in the blood to help you define whether the person is suitable for treatment or not. In general, greater than 20,000 international units per ml of blood is what is used as the cutoff point. But this is actually important if you're dealing with the wild virus, that is the one that produces the E antigen. For the mutant forms, greater than 2,000 international unit is an important marker and a point to consider commencing treatment. So remember that. The fourth factor is evidence of disease progression. Now, in most epidemiological studies, if you are 40 years of age and above, then there's a higher chance that you would benefit from treatment. Or if there's a family history of liver cancer. I must note there that in most developing countries, this H mark is not an important marker. And so, because I know that we have seen patients at 17 years of age who have had liver cancer, and so you don't have to wait up till 40 years. Remember that these researches have been done mostly in developed countries. And so each case should be managed as appropriate. Don't wait till somebody is 40 years of age before you start thinking that they will progress to disease. Of course, this is just one of the 4 factors important in making a decision about treatment. Right, so how do you evaluate patients who have chronic hepatitis B? So most of the patients do not even know that they have a diagnosis, the disease, before they come to you. They may have gone for some kind of non-specific blood test and they were found to be positive. And so they will come to you with a result. And already some of them would have actually consulted traditional healers and so on and so forth. But let's see how you should go ahead with these patients. You take a history and examination. You look at the most important things. When you're examining the patient, you're looking at evidence of chronic liver disease. We call them stigmata of chronic liver disease. I will show some of the pictures here for those who want to learn more. Take a history or family history of liver disease. That is important as it's one of the factors that you need to make a decision about treatment. Their lifestyle is also important because if they are living a rowdy intravenous drug use lifestyle, they are less likely to be compliant and or adherent to treatment. So you really want to be sure that when they're actually starting treatment, they're going to do well. Alcohol use is not great at all because it would actually inflame the liver further. So it is not the best thing for them. So you have to listen to how they are and advise them prior to going ahead with treatment for them. Traditional medications are also, of course, a big trouble. And I know that a lot of them are enthusiastic about cure, and so they can go for anything. Over-the-counter medications is also important because it can further complicate factors. Diet, including those exposure to aflatoxin. We'll talk about that later. You do a laboratory investigation looking at fibrosis level, looking at liver function, platelet count. If you have a fibroscan, perfect. That would obviate the need for a liver biopsy. You can do a viral load. Now this, in developing countries where the facilities or cost is prohibitive, there is a way out, and I will show you a bit later on. Do a HIV screen and or hepatitis C screen as well. Sometimes you may need to do an alpha-fetoprotein. Please, if you can mute yourself, it would be helpful. So it's actually coming through here. Thank you very much for that. Now, you screen patients for liver cancer because at presentation, some patients actually may already have a liver cancer. So an ultrasound may be able to pick up a nodule, and that is important. Now, this point here talks about how to estimate liver stiffness, which is fibrosis. It is simply looking at a blood enzyme known as aspartate transaminase, and then platelet count. With those two, you can actually calculate the degree of fibrosis of a patient. And upon that alone, can make a decision about commencing treatment. And so you don't have to be able to achieve doing HPV DNA. Now, this is quite an important point that is relevant for people who cannot afford or access care outside of a developed or a setting that has resources. So this is how you interpret the aspartate aminotransferase to platelet ratio index. If you do that calculation and you find that the APRI value is greater than 2, then you prioritize that patient for treatment. If it is less than 2, you consider treatment only on certain conditions, which you have seen there, prioritized based on other factors. What are the signs and symptoms? Jaundice, which is, of course, if they're jaundice at the time they're coming, they are already very sick, so you don't want that. Weakness, fatigue, anorexia, myalgia, arthralgia, that is pains around the joints, low-grade fever, and or enlargement of the spleen. Now remember, we've actually talked about this if you were present last week. So I wouldn't say too much here, but let's go to this point that looks at the signs, which I mentioned I would do that earlier. The abdomen will be swollen. That is called ascites. That is excessive fluid collection within the abdominal cavity. Now that picture is that of a man, but the breast tissues have been quite enlarged simply because of metabolic derangement in how the liver is handling the estrogens as well as testosterone. Here you see caput medusae, that is enlarged and engorged blood vessels on the surface of the abdominal wall. There you see spider nervae, which is actually something that appears on the skin of pregnant women. It's much more pronounced even in men when they have chronic liver disease. You see jaundice here, that is the yellowish discoloration of the eyes. Here the fingers will be clopped, that is fingers are quite clopped, and that is also not a very good sign. Redness of palms, okay, that is palmar erythema. Of course, this is very relevant for medical students undergoing examination. You definitely want to be confident that you know how to recognize this. It is usually in the thenar and hypothenar eminences. And of course, you can see there very clearly. And then enlargement of the spleen, okay? Those are signs that the damage has actually progressed very far. How do you investigate? Of course, this I have summarized earlier. You do biology. You then undertake certain major tests, including HPV DNA. Of course, this would be in your slide for you to review and look at. Particularly, the surface antigen is most important in making a diagnosis of chronicity. Looking at the anti-HBs and anti-HBC and all those other paraphernalia will define for you additional information in regards to how the body is handling the immunity for the virus. The types of serological markers are the surface antigen, which of course is released in excess in the blood of infected individuals. That will persist. It is only a few cases that will actually be removed after they are treated, but that persists almost for a lifetime. The core antigen is not detectable in blood. So if you see somebody having a test that tells you core antigen positive, then be very wary of that. The E antigen is evidence of replication. Now remember, I told you the viral virus will have that, whereas the mutant form may not. It does not mean much, but it's very relevant if it is present. Okay? The antibodies are there, which another time will explain that detail. But when you come into this table, which actually tells you people who are never exposed and will therefore be susceptible to infection and so on. There's so much on these slides that I will spare you this time, but because they help in defining where a patient falls. If you look at the absent and present and so on and so forth, it gives you a lot of information, but we'll proceed straight on to some aspects that I deem appropriate for this forum. How do you prepare a patient for treatment? You look for other causes of liver disease. Do HCV antibody, that is looking for hepatitis C, because that would impact on the way that you treat the patient. Do serum ferritin, because especially in those who are Europeans, because it can contribute or complicate treatment as well. For patients in Southern or Eastern European countries, HDV, that's hepatitis D virus, important in treatment as well. Okay? Don't forget, HIV is very important. It impacts on the natural cause of the disease. It also is important when you're going to make a choice for treatment of their HIV, because you will need to include a medication that works for the two viruses. Now, liver biopsy is not routinely required. I know that this will be good news for many patients and many people who don't even have facilities for that, because there are lots of non-invasive markers of fibrosis at the moment. So liver biopsy is not something that you routinely go for. However, if you have a patient who does not fulfill the criteria for treatment, and yet you still have reason to suspect that there is some activity ongoing in the liver, maybe you do a fibrosis score and it goes very high, you may consider doing a liver biopsy. That can give you a lot of information. And I must say, when I worked in Nigeria, I did do liver biopsies for patients who even had normal liver function tests. And to my surprise, they had a lot of activity in their liver ongoing, demonstrating activity of damage to the liver, and yet they do not have any enzyme response. Obviously, I didn't have HBV DNA at that time, so it would have been interesting to know what was happening at that point. So that is one factor for which a liver biopsy will be required. Right, so let's go to the treatment criteria. What are the indications? Now, this will be very interesting to many of you. Patients with cirrhosis, okay? Treat those regardless of their ALT levels. Please note this point. Those who have cirrhosis, whether their liver enzymes are raised or not, give them treatment. Whether they are compensated or decompensated. Compensated means they don't have many of the signs that I showed you earlier. Decompensated means that they have the signs already. Give them treatment. It's worked. That is the kind of international guidance agreed by the World Health Organization as well in regards to how to manage hepatitis B. Patients without cirrhosis, you do HBV-E antigen. Now remember, I told you that many of the Africans do not have the wild virus. So it's the mutant form. So HBV DNA of greater than 20,000 will be a pre-qualification for that. HBe antigen negative and HBV DNA of greater than 2,000, that is the mutant forms of the virus with a HBV DNA greater than 2,000 is a pre-qualification for treatment, okay? Now the duration of treatment varies widely. The current recommendations is to continue oral treatment indefinitely, in other words, for a lifetime. There are a few cases, and I will bring out the points later, on who should be treated and who should qualify for you to consider stopping treatment. Okay, just hold on there for a short while and you'll find that out. Of course, that's a common question. For how long will one need treatment? Many people feel very surprised and agitated when you tell them it's for a lifetime. And many have fallen victims to going to herbal medications because they believe that that's actually the way out for them. But see what I think. At their endpoints, very difficult question. But surprisingly, the answer is in the affirmative. Here, there are two scenarios. If someone had an E antigen at the beginning of treatment and they seroconvert to anti-HBe, then they are definitely a sign that they might be able to benefit from stopping treatment. If they have a surface antigen, of course, which is the definition of the infection, at the beginning of treatment and they seroconvert to an anti-HB surface antibody, then you can consider stopping treatment for them. But in either cases, you must ensure that they actually remain with anti-HBe or anti-HBs for as long as 1 year of treatment before you stop. Okay, so those are the scenarios that you can consider this. Right. Can you discharge those that do not need treatment? Listen carefully to this one. Don't think of discharging patients with hepatitis B, because those that do not meet criteria at presentation and decide to defer treatment should continue to undergo monitoring. Okay? Liver function test, HBV DNA, and HBe antigen status. Okay? It is known that over time, patients who don't need treatment, about 30% of them may actually meet the criteria for treatment. So please remember, don't discharge patients quickly. You need to monitor them. Right. So in pregnant women, what are the indications? Okay, it is now the same as for non-pregnant adults. For those whose DNA, HBV DNA is greater than 200,000, remember that? Okay. And when they are pregnant, you start giving them antiviral agents from week 28. All right. Tenofovir is the best because that has the lowest risk for women to damage their babies, and Tecovir comes after that. So remember, it's very important. The real part about treating pregnant women is to prevent their babies getting the infection. There are other ways to actually work towards this, which we'll handle later. How do you monitor patients? Okay, we're almost at the end, so please stay with me a bit and see, how do we handle patients? How do you monitor patients to see that they are doing well? One, you do a viral load every 3 months. Now, I know that this is a big thing for many people, so 6 months would even suffice, okay? You also do, if once their HBV DNA becomes undetectable, you reduce the frequency. Another thing is you do an LFT every 3 months and reduce to every 6 months, okay? You do HBe antigen antibody. Remember that that's one of the factors that you may need. The fourth thing is that you do a surface antigen every year. If they lose it, you may consider stopping treatment. How do you counsel patients? Obviously, simple. You talk to them about alcohol use. You counsel them about prevention and how to keep their families safe. Of course, alcohol, reduce transmission to others, get vaccinated family members, don't share shops, and so on. Screen for liver cancer regularly. And who are particularly of interest in this factor? All surface antigen positive patients with cirrhosis do need to undergo screening every 6 months for liver cancer, okay? It is particularly important in Asian men who are 40 years of age. If a family member has had a liver cancer, or if you're a Black person or an Asian woman who is above 50 years of age, okay? In conclusion, chronic hepatitis B infection lasts more than 6 months. If the surface antigen lasts more than that period, chronic hepatitis B is defined. If the treatment decision is guided by clinical, laboratory, and patient factors, treatment of hepatitis B is often for a lifetime. Exceptions are given to a few cases, which I mentioned, if they clear the surface antigen or they seroconvert E antigen, okay? Surveillance for liver cancer is required for several HBV patients, irrespective of treatment decision, because the virus can integrate into the DNA and cause carcinogenesis, okay? I think you've done very well to stay with me, and please think about a next booking, which is next week, the last of the series of 3 lectures. I might change this from complications of hepatitis B infection to specific complex cases. I will give the last 5 minutes or so or questions? Good, guys. Thank you very much for being there with me. And let's see. Right, you can unmute yourself if you want to ask a question, and we can go from there. Dalili, it seems Dr. Shabal wants to say something. You can unmute yourself. Okay, maybe not. Peter? Dr. Yahweh, do you have anything to say?
Hello, sir. Okay, thank you very much for the session. I think yes, you've addressed most of the issues. Yeah, most times the question we get is from our friends, from people around us is there a cure for hepatitis B? Because our competitors out there traditionally and otherwise, they keep posing and say, okay, to cure hepatitis B, call this number, to cure this, call this number. And most of them seem to have testimonies from other people that they have achieved a cure in particular people through traditional means. Even though I don't believe that, the testimony seems to be rising. I don't know if they have like a sort of arrangement with these people. So I just wanted to maybe clarify on that, and then maybe just throw more light now.
Right. So cure, as defined by the public, is different from what we define cure in medicine. And so we're very, very cautious about that definition when it comes to hepatitis B, chronic hepatitis B treatment. We have said already acute hepatitis B is curable. It self-cures itself. And so when people come onto the social media and saying that they were cured of hepatitis B, no one will tell you whether they had acute or chronic hepatitis B. And that is if their testimony is to be trusted. Sometimes they confuse herpes simplex to hepatitis, so I have no idea what they're talking about. For chronic hepatitis B, we do know, and as far as evidence is concerned, none of the herbs have ever demonstrated cure. Even those that try to boost the immunity of the body to deal with the virus, it has never demonstrated cure at all. And so, as at current, we don't have a cure. And simple reason is that it's the cccDNA, which is the integral part of the virus that can actually hide within the genetic material of the liver. And so, although there may be a transient disappearance of some of the peripheral viruses within the bloodstream, that cccDNA component can hide there and later on emerges, especially when somebody becomes immunosuppressed. And so you cannot come out after a few months of treatment, that is, if it is true what they're saying, and you come and say that you've been cured, and you don't have a follow-up data to demonstrate that that cure was real, then there's much to be taken from that story. And of course, the way we present scientific information is not by flagging up somebody's telephone number to be contacted. We do a bit more than that. So really, there's lots that meets the eye.
All right. Thank you very much, sir. So I also want to find out what is the prognosis of liver cancer, and what are the different factors that affect different factors that.
Right, Peter, thank you again. Liver cancer is obviously a bigger subject, and the Barcelona clinic liver cancer classification that gives us a prognosis depending on the size of the cancer and the biology of the cancer. And that's a big subject on itself. The reality is that for most of the cancers that we get diagnosed in developing countries, and particularly of Nigeria and some other places, it is very unlikely that most of them would meet the criteria. The definitive cure for them will be actually liver transplant. Okay, but that is some big subject that we will be of interest to many of us who will want to discuss that in detail at some point. Right, I think I've got 2 minutes left, and except there's something pressing. Does anybody want to have a comment, one or two, so that we're not cut off so quickly? Brilliant. So, guys, I thank you very much for attending. I think that I'll have an idea of who attended, and if you have not got a booking online, then your email will be somewhere within my system, so you will get an edited slide of this, and you will then be able to access, go through the lecture on your own time. Thanks very much. All right, thank you, Hilton, for wrapping me. All right, thank you. That's a good reward for my hat level. And I think all of you did well. Thank you, Dalili. You know, you're quite shy, man. Let's say something. Thank you very much for attending. Dalili is my classmate in medical school. And, yeah, thank you for the support. Please, thank you. Guys, thank you, Gabriel. Thank you, yeah, Peters. Thanks, Lucy. Thank you very much. All right, bye-bye. Thank you very much. Have a nice weekend. Bye. If you want another session by 1 p.m., that's fine. I'm going to be coming because I know some people still have the other login and they might still be coming around at 2 p.m. or so. Sorry, it will be 2 p.m. So I might be back.